Okay, so the topic has actually changed from frailty because there was a very nice discussion of frailty yesterday, and because we'll be talking a little bit about nutrition and exercise in the Meet the Professor luncheon. So I've decided to speak instead about advanced care planning, which I think is a very important topic, and it's not often discussed at our meetings, but I think you'll be able to take home some points. And I recognize there may be some cultural differences in the way that we approach this. But I do think that it is relevant in all patients across the world. So what is advanced care planning? What are the benefits? How are we doing? And I'll give you a process for early advanced care planning. Advanced care planning is really a process to help people, your patients, think about and talk about and document their wishes for their health care. And it's in the context of who they are as a person, so their personal goals, values, and beliefs. And that leads to what's called a goals of care directive, which is a medical order that's usually in the chart as to what they want their focus of care to be and where they want their care to be. So what are the benefits? And this is across many studies in palliative care and in oncology predominantly. But if we do early advanced care planning, we provide care in accordance with the patient's wishes. We reduce their anxiety. We improve their symptom management. We improve their quality of life and the quality of life of their family members as well. Importantly, for administration, we save costs. And so we decrease admissions to ICU and invasive procedures. And family members, once the patient has died, have less anxiety and less post-traumatic distress. When should we be having these discussions? And ideally what the literature suggests and what would make sense is to do it in a non-crisis setting. So not in the middle of your emergency room, but in your clinic where the patient is stable. And it's relevant to really all people. All of us should be having these advanced care planning thoughts in our head. Individualizing it though to readiness and disease stage. So in patients who are very advanced at their last few days of life, obviously we would be talking about what their wishes are in those last days. That wouldn't be appropriate necessarily to bring up with a very compensated patient. Why in cirrhosis is early initiation important? Is important for two reasons. Our patients really lose cognition with hepatic encephalopathy. Many of them have minimal hepatic encephalopathy, and so then they aren't able to fully participate or tell us their wishes. And it also allows us to identify surrogates, so people who can help them to make these decisions. From research that we've done in our own clinic, this is 100 patients with cirrhosis, very early MELD, so MELD of only 11. It was surprising to us that 50% of our patients felt that cirrhosis would have no effect on their quality of life in the future. All of them almost wanted to know the truth about their health, even if it wasn't good news. And the preferred timing of these discussions was being in clinic. So how are we actually doing right now? Even in our own clinic, before we started doing this routinely, our goals of care rate were 15%. We know from the literature that the majority of these, 2/3 of these discussions occur in hospital with a median time in one tertiary care center of a minute to have these important discussions. And in a retrospective study of 94 patients who were delisted for transplant, so they were too sick to be transplanted, still after that, half of them were admitted to the ICU and had invasive procedures such as renal replacement therapy, and 1/3 of them had a no code order in their chart, so very few. Why aren't we doing this routinely? Number one, maybe we don't really understand the importance. Number two, we don't know how to fit it into our already very busy clinics. Thirdly, we don't know how to prognosticate accurately in these patients, and we're often overly optimistic. Third, we worry we're going to cause our patients stress, and we haven't been prepared for the discussions. So we're very comfortable with our patients discussing, okay, let's do band ligation, let's do beta blockade, but when it comes to talking about symptoms and when it comes to talking about these sort of death and other plans, we're not as comfortable. So let's frame this with a case. This is a gentleman, 55-year-old male. He's got alcohol cirrhosis, refractory ascites, he's got diabetes and ongoing alcohol use. He comes in with spontaneous bacterial infection. When we get the history from what was happening at home, 3 weeks before his admission, he was also very sick. His MELD sodium was 29. He was spending most of the day in bed. 2 days after the admission, unfortunately, he had a major upper GI bleed, and he was found confused on the floor. Blood pressure of 85/50. He had aspirated, so his oxygen saturations were low. He was very sick. So his MELD sodium up to 37. And you can see the rest of his labs there. The ICU resident, so the intensive care resident, was paged urgently to see the patient at 2 a.m. in order to admit the patient to the intensive care. Flipping through the chart, there's no documentation about what the patient would want or advanced care plans. The family's phoned. The family says, Dad never mentioned his wishes, but we want everything done. So what should be done? Should this patient continue along the road to ICU, as many of our patients do? And what's wrong with this situation? So two main things. One, we don't know what Mr. G's wishes are. And as I mentioned, up to 80% of patients who are in hospital and very sick are unable to participate in their own decisions because they are cognitively not completely with it. The majority of patients with chronic disease, if you look in the literature, they wish to die at home and avoid invasive measures, but a third of them have an ICU stay in their last 3 months of life, and over 50% die in institutions. I'm not sure how that applies exactly to Mexico, whether or not that is similar. Secondly, family members who we are left to then make the decisions are often poorly informed. So in two studies, one where they looked at what surrogate decision makers, so your family members or your friends, they guessed patient preferences for CPR, so resuscitation, modestly better than chance. And a third of surrogates correctly identified treatments the patient was willing to or not willing to accept. So our family members, if we don't talk about this with them, they don't necessarily know what we want. So we've come up with a proposed way to carry out these discussions in clinic, and it can apply to cirrhosis and to other diseases. The patients at the center, the surrogates at the outside, and then the healthcare practitioners. And I'll go through some of these different wheels, and you can see that we made it purposely as a cog wheel just to reflect that it's a moving element all the time that needs to be addressed. So it includes getting to know your patient, getting to know how ready they are to have these discussions, educating them, discussing about prognosis, and documenting these things. How do we assess readiness? So in our clinics, some of the things that we can potentially say, just as far as understanding cirrhosis and readiness to discuss this, many of our patients want more information about cirrhosis and how it might affect them in the future. Does this apply to you? A good question as far as choosing a surrogate. And you should all think of who your surrogate would be in your own heads. If you were to become too sick to speak for yourself, who would you choose to make medical decisions for you? Does this person know what's important to you? You can use different figures, and these are tools that we've developed and I've laminated for use in my clinic. So this is the life trajectory figure, just to explain to patients why they're different from other patients other ways that patients die. And so we know with organ failure, and you will have all experienced this in your cirrhotic patients, they have these dips that they come into hospital with, often unpredictable deterioration, so a variceal bleed or infection, and then they gradually decline over time. But we often don't know how to prognosticate whether they're going to make it out of that dip, as opposed to frailty, which is elderly patients who just have a gradual deterioration, or advanced cancer where they have a sudden deterioration at a point in time. And so at that point in time, they're often referred to hospice. We want to learn about the patient. Do they want details? I have a lot of information I can give you. Do you want details, or are you a bottom line kind of person? Learning about their values and their hopes and their fears and what's unacceptable to them as an outcome. So what are their biggest fears about the future with regards to your health? And we often just put this down to survival, but other things are also unacceptable to patients. For example, if we told them after transplant they would be in hospital for 6 months, or if they would be on mechanical ventilation for a prolonged period of time, or have severe cognitive impairment, those things might affect their decisions for interventions. We provide our patients with education pamphlets, and this is valuable. It was designed by Dr. Guadalupe Garcia-Sao. It's a 30-page document, and it's translated in Spanish as well, and it's available on the internet. And it's a guide that goes through, that you can give to your patients, printed off the internet, that goes through when they should come in with complications and what cirrhosis is. We've also made a supplement to that, looking at advanced care planning and what the terms mean and why it's important for patients. And in that supplement, we provide them with different conversation starters so they can actually start the conversation with us, such as, are there services, for example, to help me and my family cope with this illness? What are my best days and my worst days going to be like? So just to start the conversation about things other than just their disease. There are websites that are available, and one of the really good ones is Prepare for Your Care. And again, I'm not aware of the ones in Spanish, but this Prepare for Your Care goes through so that a patient can form an advanced care directive themselves online. And then they can bring that into you and you can have the discussion with them. So it saves some time in clinic. There's education for us as well, because many of us are not well prepared for this. Most of it in English as far as I can see. I'm going to show you a short video of this best case, worst case scenario, which I love, on YouTube. And really the best thing, and what I've done, is collaborate with a local palliative care specialist. They are excellent at this, and you can get a lot of information about how to have these difficult discussions with them. We use this graph as well. It's called the life and disease graph, and you can see on the y-axis is the aim of treatment. And it's really a reflection of what's happening in the literature with palliative care and non-cancer care, that we recognize that in concert with providing disease-modifying therapies, so doing things like variceal ligation, screening them for hepatocellular carcinoma, we also need to, at the same time, provide care using palliative principles. So palliative care is not something that happens at the last few days of life. Looking for, screening for symptoms and managing them is something that needs to happen alongside and even in transplant candidates. And so we use this graph to just tell patients that they will be supported throughout the disease, not only with their disease-modifying therapies, but also with their symptoms and talking about their fears. Prognosis is a talk in itself, and so prognostication in these patients is challenging. We use different severity of illness scores. We use critical care scores, such as the Apache. We use organ failure scores, and we know that in acute on chronic liver failure, mortality is very high in patients who have 3 or more organ failures. But you also need to consider, in addition to all of the liver disease severity, comorbidities and their functional status and frailty. And so it does get to be complicated. Now, I will just show you a short video, which I think is really helpful, and I'd urge you to watch the full video online. And it's a different way to actually discuss with patients options for therapies. And so looking at it in, again, imagining outcomes that would be unacceptable to them in the context of their values, goals, and preferences, and not just giving them a bunch of percentages. So putting it in a picture that they can understand. And the case is, in this situation, is a 70-year-old man who has lots of comorbidities, and he's been given treatment for Clostridium difficile, but he's not responding to therapy. And so the doctor comes in, and I hope that this works.
Surgical problem is bad news. Patients and families need to understand that this event is unlikely to end well and could potentially result in his death. Even if he does survive, it's improbable he will be just as he was before. How can you be sure Mr. Lombardi's family understands his condition is grave? It is essential to clearly announce that he is very ill. You might say something like, "I have some bad news. Your dad has a life-threatening problem. It is going to change his life. I worry he's going to die, even with surgery. I want to make sure you understand the options." Next, introduce the best case, worst case framework. Let's look at the graphic aid. To begin, identify which options you will present. In Mr. Lombardi's case, you're presenting 2 options, total colectomy and a non-surgical option, comfort care. For each option, draw a box and a star connected by a vertical line. The box represents the worst case outcome associated with a given treatment, and the star represents the best case outcome. Somewhere along this line lies the most likely outcome. Most likely may be close to or the same as the best case or worst case, or it could be somewhere in between. The idea is for you to combine your knowledge of the patient's overall health with your understanding of the current problem to give patients and families your best estimate of what is likely to happen. Telling a story is key. This helps patients imagine an unfamiliar experience so they can prepare and make decisions based on what is important to them. While surgeons often focus on providing precise risk calculation, these numbers don't help patients envision what it is actually like to have surgery. So, how can you explain the risks and benefits? By translating the statistics you know into stories. Instead of talking about a 20% risk of renal failure and a 35% risk of stroke, tell a story about what a patient's life might actually look like if these complications occurred. You show the probability of these events by where you position the most likely outcome on the line between best and worst. Pull out key elements from your story and write them on the graphic aid. During a busy day, this seems time-consuming, but it is critical. Patients and families will refer back to this graphic aid in order to deliberate about options after you have left. Let's get back to Mr. Lombardi. If you operate on him and everything goes really well, in your best-case scenario, what would his recovery be like? Would he be able to go home again? Tell the story. If everything goes well, he will have a big operation to remove his colon, and his stool will come out in a bag. Afterwards, he will be critically ill in the ICU for a number of days. He will need a breathing machine, and he won't be able to talk. In the best-case scenario, we would remove the breathing tube a few days after surgery, and he'd stay in the hospital for another week or so before going to a nursing home, where he'll have to work hard to regain his strength. If his luck continues, he may even be able to go home again, but he will be weaker, have a bag for his stool, and need a lot more help.
So that's just a short snippet of that, but I think it's a really helpful way to tell stories and to try and make sure that our patients understand what the potential outcomes of our interventions are. So in Alberta, which is where I'm from in Canada, we divide our different goals of care designations into resuscitative care, which involves intensive care, medical care, which is on the floor and they on the ward and they do medical interventions, but don't send patients to the ICU, and then comfort care, which is just providing comfort like clysis for fluids and pain management. And so very similar, I'm sure, is something that most countries use. You want to revisit and compare and change the designations anytime there is a change in the clinical status or at a patient or family request. And getting back to our case of Mr. G, so he was admitted to the intensive care unit because we didn't know what his wishes were and the family was wanting him to be admitted. He was resuscitated and varices were banded. He was intubated. He was hypotensive still on high-dose vasoconstrictors. His creatinine was increasing, little urine output. The intensive care unit team was reluctant to start any renal replacement therapy because he was not a transplant candidate. And so there was a very challenging and heated interdisciplinary family meeting to discuss withdrawal of these life-sustaining therapies and a shift to comfort care, and he died within 12 hours. So what's wrong with this situation? The first thing is the family does not leave happy. The family has a lot of challenges with accepting his, what they thought was sudden, unexpected death, but which we all knew was very much expected given how sick he was before he even came in. And secondly, is this what the patient would have really wanted? He spent the last few days of his life in the intensive care unit, and we didn't really know whether that was consistent with his goals, values, and preferences. And we do know that if patients die in the intensive care unit, that's often associated with significantly more stress for the family members. So having these discussions earlier could have changed that whole scenario. Take-home points from this is that maybe this is a new concept of advanced care planning, or a new name anyways to something that you already do, but I think it's relevant in some form for all of our patients, and it really helps us to provide care to our patients that's congruent with what they want. It's ideally done in an outpatient setting. If you ask patients, they almost always want more information from us, and they almost always leave the clinic with fears about what is going on. We need to have honest, open communication, and we need to just practice this and get better at this, like our palliative care colleagues are, for us to become comfortable with it. And there are tools that are available online. Thank you very much.